I'll be talking about Nebivolol in hypertension, especially in diabetic patients. So if I ask you in diabetes, what is the first line medication for hypertension? ACE inhibitors, ARBs. Second line? Come on. Don't leave me alone on the stage, right? What is the second line medication? Diuretics, calcium channel blockers, beta blockers coming up very low. So my task is a little difficult to talk about Nebivolol. And when I first read about Nebivolol a few years ago, I was more intrigued to study more about Nebivolol because of some of its features that we'll talk about in this presentation. The burden of hypertension, huge burden, 1.28 billion adults between 30 and 79 years of age. 46% that do not know that they have hypertension. 21%, 1 in 5 adults with hypertension, they are just controlled. So, huge burden, undiagnosed population, and those who have been diagnosed are not controlled pretty well. So, Pakistan, over 70% of diabetics suffer from hypertension in Pakistan. This is Professor Masroor from your study in JPMC, and other data showed similar figures. So again, the complications of hypertension are huge. When we talk about diabetes, when we talk about hypertension, when we talk about dyslipidemia, the goal is to manage, to prevent complications basically. And when we talk about hypertension and its management, again, the goal is to prevent all these complications. So 10 millimeter mercury reduction in systolic blood pressure reduces coronary artery disease by what percentage points? There is a gift for this, right? I'll leave that gift to the PSIM, but there's a gift. Kitne percentage reduction is expected in coronary artery disease with a 10 millimeter mercury reduction in systolic blood pressure? Anybody from the audience? Yes? 50? No? So you reduce coronary artery disease by 17%. Thankfully none answered because we would have had to give the gift then. Hypertension, overview of guidelines. Quickly I tell you the guidelines. So blood pressure categories are more, according to the American Heart Association, normal is less than 120/80, elevated is 120 to 129 systolic, and diastolic again less than 180. High blood pressure stage 1, systolic 130 to 139, diastolic 80 to 89, and then this is stage 1 hypertension. Stage 2 hypertension is 140 or more systolic and diastolic 90 or more, and then comes hypertension crisis. And when you go to different guidelines, there is a slight difference, but the real crux is to manage hypertension and control it, rather to go into why there is some difference in some guidelines. Coming on to hypertension and diabetes, this is from American Diabetes Association. It says if the initial blood pressure is more than 130/80, but less than 160/100, of course, lifestyle management has to start. There is no doubt about that. Walk and diet is extremely crucial. But if the blood pressure is between 130/80 and 160/100, you start with one medication. And if the initial blood pressure is more than 160/100, you start with a dual therapy, as is the focus these days. So again, if there is albuminuria or coronary artery disease, you always start with an ACE inhibitor or an ARB. Otherwise, you have the option of going with an ACE-ARB or a calcium channel blocker or a diuretic. So hypertension and diabetes, the first 3 lines of medication are ACE inhibitor, ARB, calcium channel blocker, diuretic. Whatever you take in whichever sequence, of course you prefer ACE inhibitor and ARB in diabetic because of many things, because of its prevention of cardiovascular disease as well as reducing albuminuria. So beta blockers in hypertension, my role is pretty difficult today. How many of you use beta blockers in hypertension? Can you just raise your hands? मैंने किसी से कुछ नहीं पूछना. So there are people who use beta blockers in hypertension. Coming up to Nebivolol in hypertension, how many of you use Nebivolol in hypertension? Again, a few hands go up. Okay, so let's see what happens next. Beta blockers in hypertension, they reduce heart rate, they reduce contractility, lucitropy, cardiac output, decreased renin release, decreased venous return and plasma volume, decreased peripheral vascular resistance and the vasomotor tone, decreased norepinephrine release, baroreceptor resetting, anti-anxiety effects, and all these things done by the beta-adrenergic antagonists. Now, when we talk about beta blockers, there are either non-selective beta blockers where they also have alpha antagonism, And then there is beta-2 antagonism, beta-1 antagonism, beta-2 antagonism, and beta-3 agonism. Now, the beta-1 receptors, they are on the heart, so they are linked with the heart rate basically. So beta-1 blockers will reduce the heart rate. The beta-2 antagonism will lead again to the decreased chronotropy, but more importantly, they are in the vascular smooth muscle in the lungs, so they cause the bronchoconstriction, vasoconstriction, the metabolic disturbances that occur because of the beta-2 receptors. Beta-3 agonism is a unique feature for nebivolol, right? And beta-3 is again there in the heart, but more importantly in the vascular smooth muscle where it releases the nitric oxide. And we talk about it as we go forward. So when we talk about nebivolol, it has the beta-1 antagonism and the beta-3 agonism. So again, these are the generations of beta blocker. First generation, propranolol, sotalolol, nadolol, and beta-1 antagonism and beta-2 antagonism, right? Second generation were beta-1 selective, atenolol, metoprolol, bisoprolol. The third generation had beta-1 antagonism and beta-2 antagonism, but also had alpha antagonism like carvedilol and labetalol. But nebivolol is different. It has beta-1 antagonism, but it does not have the beta-2 antagonism. It has beta-3 agonism, but again, no alpha antagonism, right? So nebivolol is pretty different even in the third generation of beta blockers. And what makes it different is this role of nebivolol. So this is 1960s when non-selective beta blocker like propranolol came in, and then it was selective more towards beta-1 like atenolol and metoprolol, and then the non-selective but also vasodilating because of the alpha blocker effect like carvedilol and labetalol. But nebivolol is selective for beta-1, not affecting the beta-2, but also vasodilating because of the beta-3 agonism and nitric oxide production. So moving forward with this background, and this is the beta-1 selectivity of nebivolol, which is the best amongst the beta blockers. So issues with the earlier generation beta blockers were peripheral arterial disease, sexual dysfunction. We are always worried about erectile dysfunction and diabetes, so we were quite worried about beta blockers, of course. Disturbed glucose profile, we know that can get hurt. Disturbed lipid profile with conventional beta blockers, decreased exercise tolerance, and of course worsening of asthma and COPD. So talking about nebivolol in hypertension, nebivolol has two isomers, the L isomer and the D isomer, right? And again, the D isomer mostly on the beta-1 receptor in the heart. The beta-1 receptors are there in the heart. So this is where the heart rate gets reduced and blood pressure goes down. The L nebivolol mostly in the vascular smooth muscle endothelium, and this is where nitric oxide production starts to go up, and again it helps in vasodilation and blood pressure reduction. So beta blockers, if we talk, why in diabetic hypertensives this is important? We know the first three lines of medication are ACE inhibitors, ARBs, calcium channel blockers, diuretics. But why beta blockers in diabetes? So again, uncontrolled hypertension with diabetes we know has endothelial dysfunction, insulin resistance, we have erectile dysfunction, cardiovascular disease associated with hypertension and diabetes. And we also know that 70% of diabetics with hypertension, they will need more than one medication to control their blood pressure. So again, in hypertension, there is oxidative stress, nitric oxide reduction, and ultimately leading to atherosclerotic damage, inflammation, and cardiovascular disease. That is what happens to the core in hypertension as well as diabetes. So moving forward, endothelial stress again has multiple factors causing it. Hyperglycemia, hypertension, obesity, all these leading to endothelial stress, ultimately leading to inflammation, arterial stiffness, increased blood pressure, and increase in cardiovascular disease. So you are more worried about oxidative stress, endothelial dysfunction, atherosclerosis, hypertension, and cardiovascular disease. So nebivolol, through its action on the beta-1, decreases the heart rate, and again, through decreasing the heart rate, goes on and reduces the blood pressure. It also has beta-3 agonism in the heart vascular muscle as well, and the blood supply to the heart as well, where it increases nitric oxide and causes vasodilation. And again, the beta-3 agonism is there in the peripheral system as well, where it increases nitric oxide, increases vasodilation and endothelial function, reduces peripheral vascular reduction, and reduces hypertension, and as well as other functions that we will talk about. So coming up to nebivolol and erectile dysfunction. Now in diabetes, if I ask you how many diabetes, so diabetes through multiple mechanisms can lead to erectile dysfunction, right? Now this is a huge problem for people who are managing diabetes. So through comorbidities and through complications, erectile dysfunction is the ultimate result in diabetes. Now if I ask you, and again there is a gift, the global prevalence of erectile dysfunction in diabetes is how many percentage? And the gift, PSIM has to give, right? I'll only promise and go away. So again, what is the percentage of erectile dysfunction in diabetes? Can anybody tell me? Oh my God, you're pretty close. So before somebody answers, let me go on. It's 65.8%. You told 60%. The committee will decide whether you get the gift or not, right? 65% means every 2 out of 3 diabetic has erectile dysfunction. And remember, God has made this system for the betterment of houses. I mean, people don't tell us about erectile dysfunction, but physicians need to ask this. A happy family has to have this function normal, and we should not be afraid or shy to ask this, albeit in circumstances which are feasible. Again, moving forward, conventional beta blockers, they decrease blood flow in the corpora cavernosa due to vasoconstriction. But beta-3 agonism, remember, increases nitric oxide and causes vasodilation. The nebivolol, through the beta-3 agonism, increases nitric oxide, decreases peripheral vascular resistance, increases the blood flow, and minimizes erectile dysfunction. And this is extremely important. There are many papers. I could put a few of them on the slides. Of course, we have lack of time. Nebivolol protects erectile functions compared to metoprolol in hypertensive men with atherogenic, venogenic, psychogenic erectile function. And this shows that nebivolol may be advantageous in terms of preserving sexual functions because of increasing nitric oxide. The other paper says nebivolol seems to have a beneficial impact on erectile dysfunction, possibly due to increased nitric oxide availability, similar. And this is again nebivolol versus metoprolol, and it shows that metoprolol, of course, like other beta blockers, decreases the erectile function, but not so with nebivolol. So nebivolol and anxiety disorders now. Now, anxiety is a huge problem, right? So for people who live in Karachi, anxiety is not a new term. Even somebody rings your bell and you get anxious. Kaun aaya hai? Who's there on the door, right? So people in Karachi, and maybe the people from Lahore may not understand that well as the people in Karachi. Usko ye problem. We are the capital of anxiety in Pakistan, right? So anxiety, stress, fear, and diabetes can again lead to anxiety and depression, right? So again, an anxiety depression ultimately leads to heart attacks, strokes, and cardiovascular diseases, okay? So what should be the resting heart rate in a diabetic? If I ask question to all of you, what is the ideal heart rate? Dr. Tariq, is this your question? What is the ideal heart rate that we should have? 70? Sir, I would take your opinion quick. What should be the ideal heart rate in a person to prevent cardiovascular diseases?
50 to 60.
50 to 60. Every time I'm lucky whenever I speak on nebivolol, cardiologists are there, thank you very much, and they say 50 to 60. Now let us go back and check in our diabetic patients, what is their heart rate? Usually hovering around 80, 90 and sometimes 100. और हर बार वो कहते डॉक्टर साहब अभी भाग के आए थे अभी ये था वो तो यही है in Karachi it's like this, it's Pakistan it's like this. So we need to control, and look at this, among patients with type 2 diabetes, a higher resting heart rate is associated with an increased risk of death and cardiovascular complications. So will we only treat HbA1c and blood pressure? We'll look at the heart rate as well. So moving forward, nebivolol in combination therapy. And this is nebivolol as an add-on medication to CCB, calcium channel blocker, diuretic, the RAS medications, and every time it proves to reduce both systolic and diastolic blood pressures. Now, nebivolol for the treatment of essential hypertension, this is a systemic review. 981 trials were included, and in systolic blood pressure management, nebivolol was superior to other beta blockers and diuretics and showed no difference in efficacy when compared with the ARB or calcium channel blockers. And again, for diastolic dysfunction also, nebivolol showed similar blood pressure reduction. So nebivolol in the metabolic syndrome, right? Now when we write beta blockers, we are worried it may cause a bad impact on metabolic parameters, like for example it can increase blood glucose as well. So which receptors they cause problems with the metabolic dysfunction with beta blockers? Which receptors? The beta 2. But Nebivolol doesn't act on the beta-2 receptors. It only acts on the beta-1, which is on the heart, and beta-3 agonism, which causes increased nitric oxide. So interesting, effects of Nebivolol treatment on glucose and lipid metabolism. Nebivolol is the third generation beta-1 adrenergic receptor antagonist that must be positively used in patients with metabolic syndrome. This drug does not affect the body weight and is able to produce reduction of oxidative stress, leading to decreased insulin resistance and increase in insulin sensitivity, and is also able to decrease triglyceride and cholesterol levels, lowering the risk of cardiovascular impairment. Again, use in insulin resistance and diabetes. So, this is a study when HOMA-IR were checked, etinolol versus nebivolol. This was a 6-month treatment, and after using etinolol, the HOMA-IR score was up. Using nebivolol, it was down. So, it is proposed that it helps in insulin resistance and increases insulin sensitivity. And there are a lot of papers on this, which I could not, of course, present here due to lack of time. Nebivolol added to an ACE inhibitor or ARB provides additional blood pressure reduction with little or no effect on glucose metabolism in hypertensive patients with prediabetes. And Nebivolol in heart failure, I don't think so, I need to mention that, but 30 to 40% of diabetics will have some form of heart failure at any point in their lives. 30 to 40% diabetics. Out of every 100, 30-40% will be having some form of heart failure. And of course, in heart failure, the survival goes down by 25% if you have diabetes as well, right? So again, there are two trials, seniors trials and seniors CAD trial, and we know that both these trials showed that Nebivolol is good in heart failure. So again, Nebivolol in cardiovascular diseases, we use it in hypertension, in heart failure, coronary artery disease, atrial fibrillation, and even in non-cardiovascular diseases in diabetes and metabolic abnormalities. It writes, improves in insulin sensitivity and oxidative stress, beneficial impact on the lipids and glucose, and improvement of the endothelial dysfunction. And of course, favorable for COPD because again, it's beta-1 selective, right? And erectile dysfunction is something very important. So, in practice, if you see, so Nebivolol in summary is an antihypertensive drug which not only provides good blood pressure reduction, but also improves endothelial function, insulin sensitivity, erectile function, reduces cardiovascular diseases. Now we know that our patient cannot take 4 or 5 medications. You can't give ARB, calcium channel blocker, and diuretic, and then a beta blocker like Nebivolol, right? So my practice always has been combination medications. We have combination between the first 3 line medications in diabetes, ARB ACE inhibitor, calcium channel blocker, diuretic. सबकी combination मौजूद है, NARB with a calcium channel blocker, NARB with a diuretic, triple combination. So every time, what does calcium channel blocker do to the heart rate? Calcium channel blocker will increase the heart rate. It will, again, so many of the conventional antihypertensive therapy that you use will again increase the heart rate, and the basal heart rate is again increased in diabetes. And again, if you are living in Karachi and Pakistan, and let's, Sajid, we are here together, so maybe we can have a study, what is the basal heart rate in people in Pakistan and also in diabetics and other cardiovascular diseases. So my practice always has been to use a combination therapy at one end and to use a beta blocker like Nebivolol to control the heart rate, keep it around 60. Dr. Tariq is bold enough to say 50 to 60, लेकिन हम लोग चूंकि diabetologist or physician होते हैं, we are too worried, we try and keep it between 60 and 70 to be safe. Otherwise, जैसे मरीज आता है, nurse का phone आता है, heart rate कम है, emergency भेजते हैं, हम कहते हैं, no, 55 is also okay. But at least we should try and aim heart rate to remain around 60 to 70 to curb that anxiety effect that again causes difficulty. In the morning also in diabetic neuropathy, what I talked about was quality of life. Patient's blood pressure is controlled, heart rate is 90, he is having ghabrat all day long. Again, what quality of life have we given to that particular patient by controlling blood pressure but not looking at the heart rate of that particular patient? With 18 seconds left, I think it's time to thank you all. Thank you very much, all of you, for patient listening.